for Nahla.
Yes.
Okay, let me tell you how we do this. I'm just introducing the speakers, and then if you like to give the speakers, so I'll just the speakers are you are the moderator,
Yes.
and then you have the floor to give the speakers. Okay.
So she should introduce everybody.
Yes.
Okay.
And then I'll call you to speak.
All right. Dr. Nahla Abdeltawab, Country Director, Population Council. مش عندكم؟ Senior Associate Director of the Population Council. ماشي؟ أنا عايزة أشوف أهلا بيك، عايزة أشوف أقدر أقف هنا.
And then I will call each of you. Or you can go up to the thing, wherever you I've done two presentations orally with slides. Up to you.
عشان الترجمة.
You all have
لو سمحتي.
Okay, we're about to
Yes, there's one. You have one. Yeah,
Yes, this is mine.
that's one. That's one.
مم.
And yes, we all have.
تمام، هو بس اللي هيحفظ، لكن إحنا مش محتاجين.
وانا بقى
I see. Okay.
The closing ceremony is what?
Welcome back. Our next session focuses on human capital and population health, keys to building a resilient community. This session will highlight the interconnectedness of human capital and population health in building resilient communities. This session features the following esteemed speakers: Dr. Sameh El Saharty, Senior Health Policy Advisor, Consultant, the World Bank; Dr. Nahla Abdeltawab, International Population Council; Ms. Tanja Dedovic, Senior Regional Specialist on Labor, Mobility, and Social Inclusion, IOM Cairo Regional Office; Dr. Naeema Al Qasseer, Global Health and Sustainable Development Expert; Mr. Ricardo Lourneco, AVP Country Lead Brazil Organon; Mrs. Dawlat Shaarawy, Program Analyst Population and Development UNFPA, and this session is moderated by Professor Dr. Tim Evans, Dean of the School of Population and Health, McGill University, World Bank.
Thank you so much to our Master of Ceremonies, and thank you to our panelists for joining us today. We have an excellent session here that will focus on human capital and population health, keys in building resilient communities. Each of our panelists will give you brief remarks, and we look forward to your participation and questions following their presentations. So we will begin with Dr. Naeema Al Qasseer.
Thank you, Tim. Sabah al-Khair and good morning to everyone. I'm very honored to be here today speaking on a very, very topic which is timely today in our world: human capital and population health, keys to building a resilient community. I'm also pleased to be among distinguished speakers. Each one of them has a guru in his area or her area, and I have been pleased to work with some of them. I come from a small country called Bahrain that invested a lot in human capital with its broader definition, not only health and education, but the angles such as housing, such as safe water, such as safe gender equity, which we put always under the livelihoods, the living, which we put always under the social determinants of health. From my experience from my country, I was managed and took the experience to the region and to the globe, where we learned a lot on policy setting based on the information, but at the same time setting strategies and interventions to really respect the human being, to respect the humanity. And that is something that to me means human capital. I would be dwelling on the 4 objectives once or more because the experts will go into details, whether my friend from World Bank, who will be giving loads of information and the cost effectiveness, but also the economic return. I'll be bringing some of my experiences from working in mainly conflict countries. My background has been intensively working in countries such as Iraq, Yemen, Sudan, OPT, Palestinian territory, but at the same time studied in Lebanon during the Civil War. Now, why I say this? Because we cannot just talk about human capital, investing in communities' resilience, without looking at our surroundings and what's happening in our region, and what are the interventions that we need to take. Now, if you go to the definition human capital is mainly focused on skills, knowledge, and experiences, where the health and education are critical for people to contribute to the economy. For us, for me, as a background, health is not a luxury. Health is the core of any development and economy. Now, health with its broader sense and not the sickness. So the key points, as healthy individuals, we are the people, and we are at the same time living within an ecosystem. We are interacting, whether it's with the environment, whether it is with the planet, or whether we are interacting with the animals, which we talk these days about One Health. This is the foundation. As people, we are the foundation for development, but also healthy ones are actually foundation for the community developments and sustainable growth and economy. The World Bank says that investing in the health and education, there will be the return of a higher average of 0.5 to 1% higher annual GDP growth compared to those countries that are not investing. There are many examples, like countries like Japan, I already gave my Bahrain, but also like Singapore, countries that invested in health education very early on with rewards. The health disparities that we see today and inequality, it's also among the marginalized people, the migrants, the refugees, but also among the women and men, the gender, the young girls. The more there is inequity, we are contributing to actually the detrimental of the economic growth. Rwanda is a case that I've been following, and we know that there has been investment in Rwanda, and they met most of the MDG goals when they really invested in health and education, but broader than these two only. So what are the key impacts on the points on the human capital and health? As I said, I want to say health and not just sickness. The Cuba focus, because I've been to Cuba, for example, they have also managed to reduce the disparities. We know that for societies to be resilient and communities to be resilient, we do need to have healthy individuals, healthy families, and healthy communities. When there is a disaster, whether it is a shock because of the climate change or a shock because of the man-made conflict, how these healthy people with education, with the skills, can really come up innovation. I have seen it in Iraq, where I've served 6.5 years. We have worked the talk. The same in Sudan, where we really worked with the communities. With all the shocks they had, they could come together. Recently, the factors outside that has really impacted them to move more than once from one place into another. So the community resilience means we need to educate not only individuals, but also how the individuals within the communities can work. And I know there will be a detailed session on the community resilience. The focus is mainly sexual reproductive health, women's health, but I'm talking about generally, how can we stop the violence? We know that human capital index by the World Bank shows that for every dollar we invest in human capital, there is a return of $5 to $10 in economic growth. Now, Tim and I have worked with WHO, and when we discuss talking about the returns, we are also talking about health in all policies, whether it is policies or strategies. And that means it's not only the health sector, it means the collaboration of all. The challenges we are having as I said already, we are having political instability and conflicts in most of our countries. This has prolonged the development. This is still prolonging the development that's going on. It's costing a lot to the to the GDP annually. The Iraq sanctions, the Sudan sanctions, we cannot not talk about them because the more sanctions is actually causing less education, more destruction of educational system, more destruction of the health systems, which affects actually future generation. The decades of sanctions, for example, in Sudan and now the war, has destroyed many of the schools, many of the healthcare systems. And today we are seeing it's happening in the Lebanon. We cannot keep close eye because it will affect us. It will affect the health security of region and the globe. The economic barriers. The economic barriers when we are spending as countries, whether normal countries or the countries that are waiting to get support from others. When there is a problem, we cannot invest. We can have the best strategy, it will stay in the shelves. Same happened in Iraq and Sudan. Increase in investment of GDPs, for example, in Egypt, 5%, with a balance of having population growth. How are we managing? It's again affecting the human capitals. Now, gender inequality, I already mentioned, we have in most of the countries. We do have solutions, and there has been solutions addressing the healthcare challenges. Again, I'm speaking healthcare challenges to the wider scope. Improvement in global health life. We know the universal health coverage and universal health insurance, private sectors to be under them, will become a major emphasis for our investment in human capital. Not to forget that today, whether we are developed countries or developing countries, poor or rich, we are all affected by the mental health, stress of work, and at the same time, how can we really keep sane to be able to be productive? I want at this note to say absenteeism due to sickness is actually reducing the income of the countries and the power of productivity. There is another language is pre-entism. I don't know how to pronounce it, but actually you are not taking sick leave, but you are going to work and not productive or half productive. That's again affecting the human nature. We know that, for example, poor mental health costs global economy around $1 trillion per year, and that is a lot. Aging population, I think somebody mentioned it earlier, maybe when we were talking, but aging population is becoming a shift. It has a two-prong. It has a still, because many countries at age of 65 and institutions, at age of 65, you are no longer in the employed, you are no longer in the labor force. Countries that actually utilized the above age 65 years, like for example, we have the Singapore and we have Canada and we have Finland, actually the reward and the return of the economic productivity was much higher. There are countries that are having young population. We have major unemployment in the young population. Okay, we have managed solutions. We do have public-private people. I have the 4 Ps, started it last year from this forum. 4 Ps for me, public, people, private partnerships, because we need to have people at the core to bring solutions. That's one of the key solutions. Strengthening social safety nets. In Egypt, there is a program called Takaful and Krama. Today we have Hayat Karima, which is decent life, but also there is in Egypt now Bedaya. Bedaya is looking at the human being in totality. Decentralized healthcare, education, and health services are actually needed with the utilization of AI and technology. Enhancing women's empowerment. We have many examples, including in Egypt, in Bahrain. Women for peace is needed, men for peace is needed, young people for peace is needed. In summary, investing in human capital is the most effective way, taking the broader sense of what do we mean and redefine the human capital, building resilience, equitable systems. It might to you seem rhetoric. Believe me, I have walked the talk in smaller communities, decentralized level, and we have seen the results. So this is what we call for partnership, collaboration, communication, transparency, following the ethics, utilizing the healthcare force, especially nurses and midwives, to their fullest potential, because today our evidence shows there is lack of utilization, focused only on medical specialization, which is a loss to the development and human capital. Thank you.
Thank you very much. Lots of great starts to follow up on in terms of learning from success, managing conflict, 4 Ps to take us together and to continue to consider decentralized community resilience as a core. Thank you very much. We'll now move to our next speaker, who's Dr. Nahla Abdeltawab. Please.
Thank you, Dr. Tim. Good afternoon, ladies and gentlemen. It's my pleasure to be part of this panel to discuss human capital and population as keys to building a resilient community. First, let me start by defining what we mean by community resilience. It's the ability of a community to recover from disaster or persist sustainably in the face of a new ongoing hardship. Examples of disasters include climate change, like flash floods, like the ones we saw in Libya last year, pandemics like COVID-19, which affected all of us in one way or another, or armed conflict, which we are seeing in several countries in the region. How can we make communities more resilient? Boosting resilience means strengthening communities and enhancing their health in a way that will reduce the negative impacts of challenges, both present and future. We cannot stop disasters, but we can reduce their impact on communities by making them healthy and stronger. Building community resilience requires, among other things, bolstering the physical, mental health of the population, building the social, economic health, sexual and reproductive health of the community. Resilience cannot be achieved when health and social inequities exist. By inequities, I mean disparities in health indicators between the rich and poor, men and women, rural and urban, those with disabilities and those who do not have disabilities. For example, in Egypt, a woman living in Upper Egypt, in rural Upper Egypt, is 3 times as likely to give birth at home by an unskilled birth attendant compared to her counterpart who lives in Cairo or Alexandria. Evidence has shown that at times of crises, the more vulnerable people are the ones who are most affected by disasters. Thus, when we think about building, resilient communities, we need to target our interventions towards the most vulnerable. A first step in redressing inequities is to define those vulnerable population groups, identify key social determinants which reduce and exacerbate inequities at the local context. In this presentation, I will focus on 3 population groups whom I believe deserve special attention from policymakers and program managers, not only in Egypt, but in low and middle income countries as well. The first group is adolescent girls, especially those in rural and remote areas. Those girls know very little about their bodies and their reproductive health. The survey of young people in Egypt, conducted by the Population Council back in 2014, showed that almost half of them got shocked when they got their first menses. Mothers do not talk to them about menstrual period or menstrual hygiene. Many of those are taken out of school and get married at a very young age, in some cases as young as 12 or 13 years. Motherhood at a very young age, we all know, it exposes the girls to a risk of maternal morbidity and mortality, and also has a negative impact on their offspring. Also, research from as diverse settings as Kenya, Nicaragua, Thailand has shown that those girls are exposed to gender-based violence more often than their counterparts. Moreover, early marriage or child marriage can severely curtail educational and employment opportunities for those girls and have adverse impact. But why do parents take their girls out of school and marry them off so young? Research has shown that poverty is the main reason. When parents have no money or have little money and financial resources are limited, parents would give priority to boys' education because they will be the breadwinners and support their families in the future. So offering Awareness raising at the health facility to parents may not convince them to send their girls back to school or to delay their marriage. The good news is that there are some interventions which have been successful in reducing child marriage and getting girls back to school. Population Council researchers conducted 9 rigorous impact evaluations from around the world, found that empowerment and asset building interventions of adolescent girls can improve education, health, economic, and violence outcomes. Moreover, programs are more effective at improving outcomes when cash and asset transfers to households are combined with empowerment components like those adopted by NORA program, which is implemented by the National Council for Women in partnership with UNFPA. The second group that deserves special attention is people with disabilities. And because people with disabilities at times of crises are exposed to more negative health outcomes. They are at high risk of exploitation, violence, poor health outcomes, and even death. According to the National Survey of People with Disabilities conducted by CAPMAS in 2021, 11% of Egypt's population have a disability, be that cognitive, visual, motor, or auditory. However, there is dearth of data on sexual and reproductive health status of people with disabilities in Egypt, or the social determinants of their health. Do they get married or not? Do they have children? Do they use contraception? Which methods do they prefer? What challenges do they face in accessing sexual and reproductive health services? Anecdotal evidence, along with small qualitative studies, suggests that the sexual and reproductive health needs of people with disabilities in most parts of the world are not met. They're also exposed to gender-based violence. The study conducted by the National Council for Women, CAPMAS, and UNFPA has shown that 61% of women with disabilities who were married had been exposed to violence by their husband. The good news is that the upcoming round of the Survey of Young People in Egypt, which is conducted by CAPMAS and Population Council with support from various donors, including UNFPA and UNICEF, will include a sample of 3,500 young men and women with disabilities who will be asked about almost every aspect of their lives, such as education, employment, marriage, and reproductive health. Results of this survey should help policymakers in Egypt design policies and programs that address their needs and ensure their full integration in society. Mr. Chair, how much time do I have? Okay. Another group, the third group, which is poor working women in slum areas of Cairo, Alexandria, and other big cities in Egypt. One way to get women out of poverty is through employment. However, in many parts of the world, the work environment in the private sector is not welcoming for women, and hence many of them quit their jobs. The importance of keeping women in the workforce and creating decent jobs cannot be overemphasized. Evidence generated by Population Council researchers in several parts of the world, including Egypt, has shown that female garment factory workers are poor, work long hours, and have unmet family planning needs. They are unable to use public health services because of their long work hours. Population Council team in Egypt, in partnership with the Ministry of Health and Population, tested an intervention whereby family planning services were made available to factory workers on site through mobile clinics operated by the Ministry of Health and Population. As a result of overcoming this access barrier, family planning uptake among those women increased by 10 percentage points. This would translate into fewer unplanned pregnancies and fewer women quitting their jobs. In conclusion, sexual and reproductive health inequities are mostly a result of social, economic, and political factors that are beyond the control of the health sector. However, those factors are not insurmountable. There are several interventions that have proven to be successful in reducing SRH inequities at a small scale. There are also large-scale interventions to reduce poverty, change social norms, increase access to sexual and reproductive health services that are yet to be evaluated for their impact on sexual and reproductive health. An effective resilience building strategy will require multi-sectoral interventions and collaboration among a broad range of actors, including various government ministries, judiciary, civil society, and private sector. For governments to be able to eliminate inequities, they need accurate, timely, and comparable data to develop and implement evidence-based policies, allocate resources, and prioritize interventions. Last but not least, decentralized decision-making and involvement of more vulnerable groups in planning and management of services are key to redressing inequities in access to and utilization of sexual and reproductive health services and building more resilient communities. Thank you.
Thank you. Thank you very much, Dr. Nahla. Wonderful to see evidence on how to build community resilience in 3 discrete and very important communities that you mentioned: adolescent girls, people with disabilities, and women in slum areas. So it's wonderful to see the investments in real data to inform decentralized decision making. Our next speaker will be Dr. Ricardo Lourneco. Please.
Hello, everyone. Nice meeting you. My name is Ricardo Lourneco. I'm a medical doctor. I was born and raised and educated in Brazil. And I think what I want to do today is just to share with you a little bit or a big, small part of what I have been learning about Egypt and this region during the last couple of days. So some of the data that we have in the country could really show that we have good experiences, but also that we can benefit from learning from other parts of the world. So as a country leader in a company that is dedicated to women's health, we have this commitment of reducing 120 million unintended pregnancies until 2030. We have been half the way through it during the last 3 years, and we continue our commitment on other health situations. We all know that unplanned pregnancies, in general, they are related to higher avoidable maternal health. A lot of girls out of the school, as mentioned by my colleagues here, and other health problems, right? So Brazil is a country of immense proportions. It's, we used to say that it's a continental proportion country. It's the 6th largest country around the globe and the 8th most important economy around the globe. Yet, we still have a lot of discrepancies, a lot of inequalities in the country. And we are, I would say, when we think about sexual and reproductive rights or even unintended pregnancies, we are at the same level as so many other places in the world. Around 55% of our total births come from unintended pregnancies, but I think more dramatic than that is that unfortunately we still have every 30 minutes a baby is born in Brazil from a girl which is aged 10 to 14. That's very unfortunate. We have a lot to do about that. 70% of those mothers, they were out of school and they will probably continue out of school, right? So there are certain points that we have been trying to address, and I would focus on 3 main points to try to address the disparities that we have in an equal, and different society in Brazil. So first one is understanding the disparities. In a country like that, we have so many different cultures, so many different understandings, there's so many different challenges to be addressed. And we need our workforce, not only on health, but also on education, to be prepared to understand those disparities and speak at the same language in each of the regions that we have in a country like ours, or in a continent like we are discussing here, right? So also, we need to have a flexible workforce because we have crisis situations happening regarding health or regarding economy in different regions of the country. For instance, now we have a lot of, we are going to probably listen something about migration. We have a lot of people coming from Venezuela to Brazil in the north border of the country. in very horrible health conditions that have to be taken care of. This has to be understood. And our workforce agents, our community agents, they have to be prepared to embrace and also take care of those people, right? And the third one is about equitable access, right? Where we really need to work on, as Dr. Naeema mentioned, we have to work on private-public partnerships to make access equal, regardless of gender, regardless of ethnicity, regardless of origin of the people. So those are the three key aspects that I think we have to address. As I have been hearing during the last couple of days, awareness is one of the most important things because we have different levels of understanding. In a recent survey that we ran in Brazil with a large population from different areas of the country, we understood that the teenage girls, they rely much more on the social media than on the information that they can get from their own homes, from their own mothers. Because in general, their own mothers, they had 3, 4, 5 kids. They had no conditions to educate those kids. So they really rely on social media. They also don't rely on their closest friends because some of their closest friends, they are also getting in this poverty cycle, getting perpetuated, out of school, no education, no work opportunities, and so on. So they rely on social media. And we as the private sector, I'm representing Organon, we also have to provide reliable and quality information so that every girl can take their own decisions regardless of if, when, and why starting a family. To move forward, I would also mention some investments that could be done in terms of innovation. We have been trying to address these remote regions of the country, and although health is present in the Constitution of Brazil as a right for every citizen, it's not really available in the most remote regions. So one of the projects that we have been working on is to prepare doctors from a couple big universities in Brazil so that in the coming 2 years, 3 years, they are going to be prepared to work on telemedicine, to work on the not only the artificial intelligence, but on the tele access to the remote regions for ultrasounds, for cardiologic examinations, for prenatal examinations, and so on, right? And actually, last year, we also started a program that is following up 1,000 mothers, and the program is going to follow them. They are mostly in remote regions, and they are going to be followed for 1,000 days. So it's during the pregnancy, after the birth, and the first 3 years of the babies. And this is all going to happen from distant, not really present, because we don't have doctors available in all the regions of the country. And then finally, what I would like to bring here is something that also my colleague, Dr. Nahla, just addressed. We also have to provide information, education, and access, equal access to all women so that nobody is left behind. And when we think about information about unintended pregnancies, we also ran a survey in Brazil where 58% of women in fertile ages, they don't consider that they have the right level of information about unintended pregnancies or contraception at all. So there is a lot of information that has to be shared and achieving all the regions, different regions and populations that we have in the country. And thank you. And the last point is about the burden of women's health in the society. So there was a recent publication which is called Closing the Woman's Gap. So what is said in general is that there is a $1 trillion that could be generated if women's health was taken into a more serious level. And the regular problems, 50% of the problems are related to post-menstrual syndrome, post-birth problems, and depressive disorders, migraine. Resolving their issues, or for instance, just resolving PMS problems, could generate an additional $115 to $120 million benefits to economies all around the globe. So I think the three final points here are awareness, education of our workforce, and equal access to every woman in all of our countries. Thank you very much.
Thank you very much, Dr. Ricardo, and excellent points that give us the context of Brazil, a huge country, as you said, like all countries, lots of disparities, but very promising action, which is also building on public partnerships, of which you're a part. So thank you for those comments. We'll now move to Dr. Sameh El Saharty.
Good morning, Excellencies, ladies and gentlemen. First, I would like to express my gratitude for the organizers for inviting me to be part of the Congress and to be part of this very distinguished panel chaired by my former boss at the World Bank, Dr. Tim Evans. So, what I'm going to talk about in the next 10 minutes is investing in health for human capital formation. It's a two-way street. In 2018, the World Bank issued a report called The Changing Wealth of Nations, in which the team analyzed how wealth in nations over time accumulates. And they identified 4 types of assets. First, human capital. Second is infrastructure or physical assets. Third is natural assets like oil, gas, and minerals. And fourth is the financial assets, if the country has a wealth fund or in debt. Interesting enough, human capital constitutes about 64% of total global wealth, but expectedly with regional variations across different regions. What was really interesting is in MENA, for example, it was only 35%, while in North America was 77%. So what is human capital? Human capital is the knowledge, skills, and health that people accumulate over time throughout their life to make them productive in the economy. So the whole purpose of the human capital is to ensure that people are healthy, educated, and skilled to be productive in the economy. And human capital actually starts from the very beginning, from pregnancy, birth, childhood, teenage, adulthood, through aging. So it is actually, it spans the entire life cycle. So starting from the very beginning, from Bidaya, as my previous speakers talked about the importance of maternal and child health, safe motherhood is actually a human capital intervention. So starting from the very beginning or Bidaya, interventions aiming at ensuring that women receive high quality care during pregnancy and childbirth improves future productivity and increase income of the newborn. A study that assessed the impact of unfavorable in utero or during pregnancy conditions concluded that they can lower annual income by 5 to 10% during adulthood. So, as I mentioned, safe motherhood is not just a health intervention, but also a human capital intervention. Moving along the life cycle, early childhood interventions have long-term economic impact. Stunting has a profound impact on brain development and long-term cognitive skills. The picture that I'm going to show is a brain MRI, and it shows the size of the brain and the number of neurons, the brain cells that are there in a healthy child. And compare this with the next image, which is the brain of a stunted child. Look at the size of the brain, look at the number of neurons, and expectedly, this child will have cognitive impairments in the future. The economic losses from stunting is about 7% in per capita income. Reducing stunting by 10 percentage points may lead to 3.5% productivity increase. So investing in the first 1,000 days, or the golden days, as my colleague Dr. Abla Al-Alfi always talk about, the golden days, is both a health and a human capital intervention. Moving on again along the life cycle, every dollar invested in early childhood development can yield between $6 to $17 in economic returns and benefits. $1 gives that much return in the future. And this is the return from investing in early childhood development on economic and social benefits. This is followed by early child education, the preschool programs, followed by schooling and improving learning outcomes, and finally on-the-job training and skills development. So the earlier we invest, the better return we get as marginal utility declines over time. That doesn't mean that we should not invest at any time. Any investment at any stage of life is critical, but the message here, the earlier we invest, the better outcome and the better return we get on our investment. Early childhood education is associated with positive education and health effects. We always talk about early child education as an education intervention, which is true. Evidence from systematic reviews and meta-analyses showed that ECE is associated with positive academic achievement, cognitive development, self-regulation skills, and socio-emotional development, but also positive health effects, including healthier weight as well as better health equity. Now, one of the major challenges that we are facing globally is non-communicable diseases. In fact, 85% of children aged 15 years will survive to age 60. That means 15% of those who are born today will not make it to age 60. They will die prematurely. This scatter plot looks at the variation across the globe, and you can see the dotted lines are MENA region. Most of the countries in MENA are above the trend line, which is fine. Still, there is a lot of work to be done in this space. Evidence suggests that improving adult survival rate by 10 percentage points leads to 6% increase in productivity. But let's remember that adult survival is mainly affected by the non-communicable diseases, which are responsible for most of the premature deaths, thus loss of productivity and loss of potential years of productivity. So this chart looks at the proportion of all deaths attributable to NCDs by country income category from 2019 to 2040. Now, right now, the global burden from NCDs is about 74%, and this is expected to rise to 90% in just 15 years. The main NCDs, as we all know, are caused by a few modifiable behavior risk factors. And many of these unhealthy behaviors start at early age, like smoking, unhealthy diet, and lack of physical activity. This chart looks at the MENA region. And as you can see, a high percentage of young people in MENA use tobacco products. Smoking is very prevalent in our region. Similarly, a high percentage of young people in MENA are either overweight or obese. In fact, our region has the second highest burden of diabetes as well as obesity after the East Asia Pacific Islands. Now, economic losses from NCDs are not just about premature death or mortality, but also morbidity in the form of lost productivity. Let me pause here for just 30 seconds. Imagine a person who is 45 years old who had heart attack and dies in a country where life expectancy is 65 years. So that means the economy and this country is going to lose about 20 years of potential productivity if this person did not have heart attack and has lived through the life expectancy of 65 years. So this is premature mortality or premature death. Another scenario, he was saved, he got a heart bypass, and he survived to age 65. However, he was less productive than a full healthy person. We call this lost productivity. And this is represented in a number of indicators like direct medical cost, the cost of medical care, but also productivity loss. And here we have two indicators. One is called absenteeism, simply when the person is sick and he or she is absent from work because of his chronic condition. But the second, which is usually neglected, we call it presenteeism. When this person comes actually to work, but still on work, he is less productive than a full healthy person. We did a study in the Gulf Cooperation Council countries, and here are the results. Overall cost of productivity losses in the GCC was 80 billion US dollars, which equals to 2.7% of GDP. And there are large country variations from Oman up to Qatar. But as I mentioned, the cost of presenteeism is 4.5 times that of absenteeism. So in a nutshell, I didn't have time to go through healthy longevity, but investing in safe motherhood, in early childhood development, in early child education, in reducing risk factors for NCDs among teenagers, early detection and management of non-communicable diseases, and ensuring care economy for the elderly to make them live a healthier life and healthy longevity are all health, but also human capital investment. Thank you very much for your attention.
Thank you very much, Dr. Sameh. Wonderful life course view of how investing in human capital is not only good intrinsically for those who benefit, but instrumentally for the economies and societies in which they live. Thank you very much. And we will now move to our next speaker, which is Ms. Tanja Dedovic. Over to you. You may need to go up there.
So, good afternoon. For me, this is the first time being here at this council, and thanks to my previous speaker, I have at least one linkage to talk to you about investment in human capital, because I'm coming from a completely different field. I'm a labor migration specialist. So I am going to talk to you about investment in human capital and how that can enhance health outcomes for the populations, both in the countries of origin, but also in the countries of destination, where these health workers are coming from and where they are going to work. I thought that I would give you first maybe a couple of good examples how labor migration governance can enhance investment in human capital, meaning investment in the health workforce. Thank you. Thank you. All right, thank you. I'm looking primarily at examples from this region. And as you can imagine, a lot of the examples about the health workforce are coming from the Gulf. So one of the good examples that we have in terms of governing labor migration governance is the agreement between Bahrain and the Philippines. Because I'm citing that example because here we are looking at an agreement which is already going back quite some time, so it's also an important example because Bahrain was one of the first countries that actually foresaw an investment in the training of the health workforce that is then coming to Bahrain. We are having other examples between, let's say, the UK and Kenya as well, where the government of the UK together with Kenya, and importantly here, I think is to emphasize the involvement of the Kenyan Union of Nurses. They all work together to come up with this agreement between Kenya and the UK, and also
anticipate future demographic trends and start adapting institutions, infrastructure, and policies accordingly. That also includes the toolkit supporting the fertility preferences and people's informed reproductive choices. Assure universal access to sexual reproductive health and rights. Invest in youth, enable young people to build a future in a place of their choice. Establish family policies and strengthen the care system for both young and children, nurseries, and for the age population to build strong, diverse, and resilient families. Continue advancing, of course, gender equalities and plan for and adapt to urbanization. Promote inclusive societies, including safe, orderly, and regular migration. Human capital. It encompasses the education, knowledge, skills, health, and well-being of individuals that enable them to participate fully and meaningfully in society and contribute to sustainable development. So how human capital contributes to resilience? It's the logical flow, of course. Healthier population will better be able to withstand shocks and adapt to changes. Educated individuals will be more empowered to make informed decisions. A skilled workforce will drive economic growth, and that will lead to greater resilience. So UNFPA adopts a holistic approach where health, education, and empowerment, especially for women and young people, drive sustainable population growth and brighter future for all. The approach to human capital, through collaboration with governments to invest in human capital by strengthening data systems, promoting reproductive health and rights, addressing gender-based violence, and empowering women and youth. We start by recognizing the importance of focusing on sexual reproductive health and rights for all, emphasizing that it's a cornerstone for human capital development. As universal access to SRH or information and service empowers individuals to make informed choices about their lives, leading to a better health, education, and economic outcome. It's like the foundation for anything. Also, it considers empowerment of women and girls, gender equality and agency of women, including ending gender-based violence and harmful practices like FGM and child marriage, are essential for unlocking human capital. Adolescents and youth are critical demographic groups for human capital development. Through investments in their education, health, and skills needed for the 21st century workforce to reach their potential and harness the demographic development. Also the approach, we're focusing on data-driven policies, collecting and analyzing population data to inform policies, since disaggregated data address disparities and make the invisible visible, support stronger institutions, addressing inequalities, supporting healthy aging, embracing migration. Also, I would like to refer here to our the National Population Strategy in Egypt. It has one pillar on human capital, where it prioritizes young people and youth and the age population as well. These are some of our work in the field here in Egypt, reaching people where they are. This is one picture from our youth program, trying to utilize innovative approach to engage and pass and raise the awareness of young people on our age education, on the risk of gender-based violence. The other picture, we're investing here on GBV services to empower survivors and build community capacity to address violence and foster resilience and social change. Also, we support at UNFPA the midwives. We have a global midwife strategy because this will help with a sustainable workforce. And UNFPA in Egypt participated in the development of the midwifery strategy with the Ministry of Health and, of course, with the WHO. This is building a future powered by Egypt's population, navigating the demographic trends. This is a policy paper developed by our country office in partnership with Cairo Demographic Center, and the author was Dr. Maged Osman, the well-known expert. It measures resilience. It's an effort to try to measure resilience at the local level using a number of indicators, then coming up with a composite index, in addition to other proxy indicators like demographic dividend, child dependency, and climate change vulnerability, another proxy indicator, so that we were able to map governor's performance regarding these three proxy indicators to give us insights to know the ability and the performance of the governors when we look at these three dimensions and how far they are resilient, and also to inform, of course, adaptation and planning. This is also the value proposition regarding climate change. We're talking about 4 pillars to strengthen individual resilience, strengthening the system's resilience, health, education, prevention, reducing risks through preparedness, and also strengthening the data. Also, we did a study here with the Ministry of Health and Population on assessing the impact of climate change on the reproductive health of women and girls in Egypt. And there was recommendation to develop a strong health surveillance system to track the impact of climate change on reproductive health and indicators. So stronger people, it means stronger communities. A community with a skilled and healthy workforce is better equipped to respond to shocks. And also communities with higher levels of human capital are better equipped to adapt to change and uncertainty and mitigate risks and shocks. The key takeaways is demographic resilience is essential for thriving communities. Invest in SRH, gender equality, and education, and decent work for all. Governments can best support communities by focusing on mitigating the factors that limits people's choices, implement gender-responsive family policies that foster family-friendly workplaces, and promote social inclusion, strengthen care economy for healthy aging. UNFPA views human capital as a holistic concept that encompasses health, education, skills, and well-being. This is the resources that I mentioned, and here is the links if you're interested to have a look. And thank you very much.
Thank you very much, Dr. Dalla, for that which I think has added to this panel this sense of can-do, and that really dynamic demographic diversity is a strength for people, prosperity, and the planet. So you've really, I think, pulled a thread through all of the presentations, and I'd just like to reflect, you have a great diversity of UN institutions represented on this panel, as well as private citizens who and private institutions that are aligned around this opportunity of human capital as a hugely centering asset that we can collectively build to tackle the challenges that face us. So thank you to all our panelists for their excellent initial remarks. It's now time for the quiz. Over to you, and raise your hand, please. There are microphones that will be identified, and I see at least 2 hands. We'll take the first one here directly in front of me. 3rd row back, center. And just if you can stand up, that way the people with the microphones can see you.
Yeah, hello. Sound is good?
Yep.
Yes. Hello, my name is Mahmoud Sarwat. I am a student at the Faculty of Economics and Political Science. And in the beginning, I would like to send my greetings to Your Excellency. And I have 2 questions. My first question is directed to Dr. Sameh and Dr. Naeema. My question is there a specific mechanism to deal with refugee crisis in neighboring countries in Egypt? And the second question is directed to Dr. Tanja. How can we benefit from this MBS program that you are mentioning in your presentation, and in formal levels and formal levels? Thank you.
Great. Thank you very much for that. Those two very clear questions, and we'll give our panelists a little time to think about them. We'll take a few more questions. I saw one at the back. Okay, we have one at the back here. Hello? Do we have the microphones continuing to pass? Yeah. We have at the very... Yeah, do we have more than one microphone? Okay, yeah, and then next to the left.
ريهام رجب مدير وحدة حكام محافظة الشرقية. بشكر حضراتكم جميعا. كان سؤالي للدكتور تانيا، هل التدريب فقط كافي للاستثمار في الموارد البشرية، خصوصا ان فترة التدريب بتكون موحدة مع الأخذ في الاعتبار ان اختلاف الثقافات ووعي الأفراد التي تتلقى التدريب، وهل من حق الأفراد اللي في البلدان اللي فيها صراعات أو حروب برضو التدريب، ولا بتبقى محرومة من التدريب؟ وشكرا لحضراتكم.
Great. Excellent questions again, and we'll move along that row to the next person. Thank you.
عمرو محمد، لماذا لا يتم إعادة تنظيم رأس المال البشري من خلال المنظمات الدولية وبصفة خاصة صندوق النقد لما له من اشتراطات تقبلها الدول لقبول القروض؟
Very good. Thank you for that. Again, short and clear question. It's going to be a tough answer. And now I've got at the very back, and then I have one other hand, and we'll go with those first 5 questions. Yes.
First, my name is Dr. Muhammad Nabil. I am from Nile for pharmaceutical and chemical industry here. It's my honor to attend here through your conference, and appreciations your efforts for working for that. So I have one opinion about something. Training is very critical and very important for changing over the world. How can get the training for improving our working, our designations of our work? So I need for this answering. Thank you.
Great, thank you very much. And we have one further question. Yes, thank you.
سؤالي للدكتور سامح، ماذا عن تمكين بعض الفئات الخاصة زي الأشخاص ذوي الإعاقة وكمان المتعايشين مع HIV، مجتمع ميم، في أكتر من فئة قوة بشرية وإحصائياتها كبيرة جدا، وفي نفس الوقت كسياسات الوزارة نفسها نحو التمكين الفعلي نفسها في التنمية البشرية. شكرا.
Great. Yeah, we have, I'm conscious we have 2 hands on the left or 3 hands on the left, which I have trouble seeing because of the light. But I do see we've got right here in the front row on the left, right here, front row. Yes.
Good morning, and thank you for the presentation. There is a lot of knowledge I know today I didn't know as before. I have 2 questions. How we can develop a sensation of the importance of community participate in investment in human capital, and how can we integrate ministry such as culture, education, endowment in the different way to be present the knowledge about how it's important to invest in the capital human.
Excellent.
Thank you.
2 great questions again, and so brief. Our questioners are fantastic. Congratulations. You're going to get great answers. We have one at the back. second row from the back, and then we have another question over here on the right. And then what we'll do is we'll give our panelists a chance to respond. Please.
Okay, my question is directed to the whole panel. Actually, Egypt has exerted lots of efforts in the area of population control. And if I had to cite some examples like girls assets framework led by NCCM, National Council of Women, and the national projects for the development of the Egyptian family, the Golden 1000 Days, and so forth. So my question is, what is your assessment or insights regarding the Egyptian experience with regard to in the area of population control?
Great, thank you. And our final question before we come back to our panelists, and I'm giving my panelists fair warning, you will each have 2 minutes to respond to whatever question you would like. Okay? Only 2. Thank you.
Thank you. My name is Sameh El Saharty, Zalingi University Faculty of Health Science, Sudan. Really, I'm very interested for this very informative session. I have a question for the panel. How we can foster or how we can promote the collaboration between the health and education sector to build the resilience among the population. Yeah.
Great.
Thank you.
Okay, excellent questions. Some of them are overlapping, and I'm going to begin with Dr. Naeema. You have 1 minute and 59 seconds.
Thank you. Thank you very much. All very, very valid questions. First of all, with regarding of inclusions of refugees, migrants, disabled, one of the lessons learned from field is the more they are inclusive, the more better outcome we have, whether they are health workers, school teachers, and others. I want to say from this forum last year, there were different civil society communities, youth engagement to set up the strategy for Egypt, which actually worked on it. Coming with the different collaboration between the two sectors, when we talk about multi-sectorial, multidisciplinary, health is yet to scale up. They're really putting the multidisciplinary around the table, and that is serving for both refugees and everyone. Jordan, for example, and Egypt have included in their services the healthcare provided to the people. I want to come back to the issue of how can we have resilient communities? We are communities. If we do not start from ourselves, in our neighborhoods, with our families, we cannot do so. It's a critical mass to be established to do it. Healthy livings, and already was mentioned, whether it's obesity, whether it's heart problems, whether it is mental disorders, substance abuse, starts from homes. We have forgotten to mention about the role of the media, the journalism, the marketing that's going to happen. Yesterday was excellent session on the tobacco, fighting the tobacco, and at the same time His Excellency, for the first time I hear him, the very clear policy of direction, really focusing, investing on well-being and healthy people. We need to redefine health. Ministry of Health, he said, is health, is not Ministry of Sickness. And I want to close here.
Thank you very much, Dr. Naeema. We will have Dr. Nahla.
Okay, thank you. I can respond to the question on population control. First of all, it was never the aim of the government to control the population. It was to promote family planning. And family planning is the right of couples and individuals to decide when to have children and the number of children that they want to have. And my answer is, look at the data. If we look at previous demographic and health surveys, we find that on average, let's look at the mid-80s, on average, a family would have 4.5 children. That's to say, 10 families would have 45 children. So today, the average, as Dr. Hussein Abdelaziz mentioned this morning, is less than 3 children. So in terms of numbers, we have made a great achievement. In terms of awareness of family planning and of how to prevent pregnancies, awareness of contraception, it is almost universal especially among women. some of the governorates, like Port Said, for example, is having, the couples are having even less than 2 children. So in terms of achievement, we have done a lot, and we should be proud of what we have achieved. There are certain places like rural Upper Egypt which still are struggling, but the reasons are social, as I mentioned, and that's where we need more involvement of other ministries like Social Solidarity and Ministry of Education.
Be starting at 1:30. Kindly remain seated.